Okay, so we're gonna go through a few cases. I know it's hard to be more interactive when you guys can't talk. Whoops. Okay, I'm gonna open my chat box, I think, just so that I can see you guys. All right. First case. And these are all real live cases. So this is a 63-year-old male. He had a history of a melanoma, currently on nivolumab, and surveillance imaging revealed a left thyroid nodule. His TSH was 10 and an ultrasound was performed. So here's his ultrasound. You can see this nodule here. Does anyone want to describe this nodule for me? You can do it via the chat. So describe the echogenicity, the margins, whether it's regular or not. Yep, so I agree, it's solid. It's not, it looks pretty well circumscribed, and it's a little bit hypoechoic. I agree. Here's another view of it. And in this view, it looks a little bit more isoechoic. And what are these little bitty things in here? Microcalcifications, correct. So an ultrasound biopsy was performed of that nodule, and it came back as indeterminate. So as was custom, it did go off for ThyroSeq, and here is the ThyroSeq result. So this is a typical way that it would appear. And so the first thing people see is, oh my God, it's positive. This guy's got cancer. Send him right away. But actually, it's very, very important to look at what it's positive for. And in the newer ThyroSeq reports, which with the V3 results, there is a much better description of what the test result means. So in this case, it was an HRAS mutation. This having HRAS mutation has a very high chance of having either a NIFTY-P and or a cancer. Now, unfortunately, we're not able to tell the difference between a NIFTY-P and a cancer. So to back up, I didn't talk about NIFTY-P in my talk, but it is a non-invasive follicular thyroid neoplasm with papillary-like features that is considered a benign process. This used to be considered a low-grade thyroid cancer, but about 2 to 3 years ago, it became reclassified as a NIFTY-P. And therefore, this result is that you have a 70% probability of a cancer or a NIFTY-P. And other than that, we can't really tell the difference between whether it's malignant or not. So in this case, do you think any of you guys would recommend surgery? Remember the ultrasound characteristics of the microcalcifications. It's pretty well circumscribed. Who would recommend surgery versus observation? And he does have a history of melanoma, remember that. Yeah, I think the status of his cancer, I think he is on maintenance nivolumab. So he doesn't have any active disease of melanoma, but he is on this maintenance dose for what I understand for a long period of time. But that is very, very important to bring up because you're not operating in a vacuum. It's important to have that conversation with the medical oncologist. And yes, there are some healing issues that can occur. However, luckily for us, Healing in the neck is usually not a big problem, but that is a very important point to look at. So I did offer surgery for this patient, and hemithyroidectomy, total thyroidectomy. I did offer a total, mainly because of the location of where the mass was. And it did turn out to be a thyroid cancer. He is, and I should mention that prior to the surgery, we did do a lateral lymph nodes and central lymph node assessment, and there really was nothing. So he should be done with his treatment for his thyroid cancer. The interesting story about him is that the first time I met him was about 14 months prior to the surgery, which he eventually agreed to. And the first time I saw him, we discussed either observation or surgery. And at that time he wanted to wait. And so he came back a year later. So he did have some surveillance in there as well. And there was noted to be no significant growth, just a minimal amount of growth. So would I have considered a PET and brain MRI prior to surgery to restage? I think that I did not do that, mainly because I had the conversation with his medical oncologist who was treating him for his melanoma, and she has been doing all the surveillance for him with regards to melanoma, and she assured me that he did not have evidence of any recurrence or persistent disease. But again, that's a very good question. So moving on to case 2. We have a 50-year-old female. She had a total thyroidectomy in Jamaica, and therefore, you know, obviously we can't get the slides and all that stuff, but we did have some reports. Now she presents, and it was probably about 5 years prior to her presenting to the clinic. She presented with a right neck mass and a left paratracheal mass. Her TSH was well suppressed, her TG was 2, but she had positive antibodies. So here's a CT neck. Somebody wanted a CT neck, and we got a CT neck. So it shows this mass here in the supraclavicular level 5B region. And you can also see this left paratracheal mass. Let's see if I can. So we biopsied both, and it was cancer. And we did bilateral neck dissections. The question is, do we do systemic therapy or do we do RAI? The path was papillary thyroid cancer. I think it would be reasonable to consider another dose of RAI, mainly because her antibodies were so high. And even though we can't really follow her thyroglobulin, it would be good to go ahead and see if she could be stimulated. So Robert has here a stimulated I-123, so a whole body scan prior to the RAI. I think that's a reasonable approach. However, that's a very low dose stimulation. And I think it's better to go ahead and plan for thyrogen and the whole sequence of events to do the ablation. And that might be what you're trying to say in your comment. Again, it's difficult to have a discussion without being able to talk. But yes, so we could do thyrogen for 2 days and then do a whole body scan and determine if there's uptake. But even with that small amount of dose that we give for a whole body scan, I do think that I would, even if it didn't show much on that whole body scan initially, I would go ahead and ablate her with a fairly large dose. So another complicated patient, 44-year-old male. He had a history of archaeectomy and XRT in 2004 for seminoma, and also had a liposarcoma. So two previous malignancies. has had a left-sided thyroid nodule for some time. TSH is normal. Okay, so describe the nodule. Echogenicity, margins. It's about 2 centimeters, as you can see. Anybody want to respond? I would say it is mostly solid. It's a little bit more heterogeneous than the previous one, but it's mostly solid. And I would say it's isoechoic. Ultrasound guided biopsy was performed, it was a Bethesda 5. And here's the ThyroSeq report here. Now, the reason why I wanted to bring this up was because it's BRAF positive. So what do y'all know about BRAF with regards to thyroid? So BRAF used to be a tool that we could prognosticate thyroid cancer with. It is no longer considered to be a prognosticator. It is something that we see very commonly in thyroid cancers, but it doesn't necessarily mean that they're going to have a more aggressive or more lethal course. The most important thing to know is that if you do have a nodule that's BRAF positive, then it's really thyroid cancer until ruled out otherwise. It doesn't necessarily mean that they're going to do worse. Now, probably about 10 to 15 years ago, we were checking BRAF on every single nodule and every single thyroid cancer because we had this phenomenon or this idea that it was going to be worse. But it really has not proven to be the case. And in fact, it's a very poor prognosticator for thyroid cancer. So the main reason why it's checked is to try to push it to one way or the other. So if it was BRAF positive and it's a Bethesda 5, then that's a Bethesda 6. That's thyroid cancer. And therefore, I would treat it as, I would have the discussion with the patient as if the diagnosis is Bethesda 6. And that's the main reason why BRAF is important with regards to thyroid nodules. Now, in other diseases, it can have a different prognostic indicator, but as the other thing that's important for BRAF also is if you're looking to treat them with systemic disease, checking for BRAF mutations can help because there are some kinase inhibitors that work for BRAF positive disease and some that don't. Okay, case 4. We have, why does a ThyroSeq get sent if Bethesda 5? That's a good question. In this case, I didn't order the cytology and it came from an outside institution. And so that's why it got sent. Sometimes the reading cytologist or reading cytopathologist may want to have a additional ThyroSeq testing, but I usually don't get a Bethesda 5. I don't usually send that out. Okay, right thyroid mass, 5 centimeters. All right, here's another ultrasound for those of you who haven't responded yet. This one's more ugly, I think. So you can see here, if you look at the muscle, you kind of lose the border of the strap muscle overlying the thyroid. So there is some consideration that the margins are invading, just like, and it's hypoechoic, extrathyroidal. I like how that auto-corrected. Yes, definitely extrathyroidal extension. Now you can see how this is spilling outside of the thyroid itself. and it's quite ugly. So the biopsy result was follicular neoplasm. It did not turn out to be cancer. And again, this came from an outside, they did not have thyroid. So would you re-biopsy her, or would you just go to surgery? So I think part of the thinking process is that we should all only do diagnostic testing or further diagnostic testing if we think it's going to change our management. So and let's go back and look at this ultrasound. So we already talked about how ugly it looks, how it's going outside of the thyroid. I don't know of any sort of benign thing that can really do this, especially if it's so, here's some normal thyroid here. So it isn't like the entire thyroid's replaced by this, or if there's some sort of thyroiditis approach. So I'm already thinking this is something that's really weird and bad, and I think you should have it out. So in this case, I would not, I don't think that doing another biopsy would really help me decide whether to do surgery or not. I'm pretty much deciding to do surgery. And therefore, I would recommend that we just move forward with surgery. Now, the patient may say, no, really, I really want to have another biopsy. It's not a cancer yet, and therefore I need to do another biopsy. But I would just explain that this really, the results of the biopsy, even if it came back benign, I'm not going to say, okay, fine, you have benign disease, go away, you don't need surgery. I would still recommend surgery. So therefore, many times, because my decision has already been made to do surgery, I don't think another biopsy, whether it's core or not, would really change my management. Now, I don't do core needle biopsies in the office. I will do fine needle biopsies in the office, but I don't do core needle biopsies in the office. And that's just because the risk of complications is much higher with core needles. So I'm not comfortable doing core needles in the office. And I'm sure my office staff is also grateful that I don't. So anyway, the patient did have a follicular carcinoma that turned out to be quite involved with central lymph node involvement. So let's move on to this patient. 38-year-old healthy Korean male. This is very common in Korea. You can, and actually here in the United States now, I mean, we get, you guys are, some of us who are older will get these flyers in the mail that say, oh yeah, you need to have a whole body exam, go to this 18-wheeler trailer in the parking lot of Walmart and you can have your whole body surveyed to see if anything's wrong with you. And similar things are done in Korea. He actually lives in the United States, but his mom convinced him to go have a full body exam in Korea. And the incidental finding, lo and behold, was a 7mm nodule. They did biopsy it and turned out to be PTC. So he comes back to the United States, having had this full body exam with a diagnosis of papillary thyroid cancer and a 7mm nodule. And so he comes to us saying, okay, what should I do? 38. How would you all counsel him? So we got 1 vote for observe, 2 votes for observe. Yeah, but we, you know, someone says we shouldn't have biopsied it. That's true, but it's been biopsied. That's water under the bridge at this point. So yes, I do think it's very important to do a real neck ultrasound at this time and to determine if there are any lymph nodes. And in his case, he did not have any lymph nodes in his neck, and he had a very thorough ultrasound of the lateral necks and central necks, and this really was the only thing that was there. We went through the whole risks and benefits of active surveillance versus hemithyroidectomy versus total thyroidectomy. with him, and he opted for active surveillance. And I had him sign a consent form, and he comes back every year. This past year was his 4th year of active surveillance. And every time I see him, I offer hemithyroidectomy and say, if we do a hemithyroidectomy, you'll be done with this and you won't have to come back anymore to really, you know, worry about it. We can look at the other side, but it's not as big a deal. And this year was the only year he kind of was interested in maybe having a hemithyroidectomy. But again, he decided to make another appointment for another ultrasound. But every time you see these patients, if they're undergoing active surveillance, it is very, very important to look at the lateral lymph nodes. And the reason why I say that is because I have another guy who's also a Korean male, but he was older. He was like 58. And he also had a very small sub-centimeter nodule in his thyroid gland. And one time, the initial evaluations did not show any lateral lymph nodes, but then one of the subsequent ultrasounds, he did have a level 2 lymph node that was getting larger, and we needled it, and it turned out to be PTC. So he had a sub-centimeter thyroid cancer in his thyroid, but he developed lateral lymph node disease. So then we ended up having to take him to surgery and do a total thyroidectomy and neck dissection. But so that just indicates how important it is, and many of you guys recognize that, to really survey the neck, because once they have lateral lymph node disease, then all bets are off the table for active surveillance. So this guy is still undergoing surveillance. Okay. Case 6, 45-year-old female, has a 2.5 centimeter solitary thyroid nodule. FNA is consistent with PTC. There's no evidence, so we did do a neck ultrasound, and she comes to you because she's planning to undergo a total thyroidectomy, and she wants to know whether she should have a central lymph node dissection. You're her 3rd surgeon to shop. So what would y'all say to her? And you don't know what the other 2 surgeons said. I don't see any. Oh, here we go. Here's some responses. Okay, so most of you guys, at least all the people who responded, say, well, there's one who says that they would do a neck dissection, a central node dissection, and others who said no. So in this case, I don't think I would do a central node dissection unless I saw something intraoperatively that was like, wow, what is this thing? And then I would send it for frozen. And this allows me to discuss one small thing that I think is important. If you do see something in the central neck, don't assume it's a parathyroid gland. It might be a met. It might be a small met. And if you were to reimplant a small met into the strap muscle thinking it was a parathyroid gland, that can have negative results. not really a good outcome. So I think that if you're thinking it's a parathyroid, I think it's important to go ahead and take it out, send a small portion to pathology, have them do a frozen section on it, determine whether it's a parathyroid gland or not, and then decide whether to implant it into the muscle. I have taken out many lymph nodes that were in the strap muscle because they were implanted thinking that it was a parathyroid gland. So I think I'll use this case to really, because we've already kind of beat that horse to death with the whether to do a prophylactic central lymph node dissection, but I wanted to use this case to offer some wisdom with regards to removal of central lymph node soft tissue and whether to reimplant it or not. because you do want to, if it is a parathyroid gland and you have, and it's devascularized, it is a good idea to go ahead and reimplant them, but only if you can confirm that it really is a parathyroid gland. In this case, I don't think I would do a prophylactic central lymph node dissection. All right, moving on. Case 7, 48-year-old female, status post total thyroidectomy, 2 years ago, did not have a central lymph node dissection. She now has a 8 millimeter right level 4 lymph node. Her suppressed TG is 1 with negative antibodies. So a suppressed TG means that she is still on her levothyroxine. If you were to stimulate that, it would probably go up to about 5 or 6 or even higher. And I think that's an important laboratory data for all of us to consider when we are treating thyroid cancer, is to understand what a suppressed TG is versus a stimulated TG. And so the way that you can tell whether the TG that's being reported is suppressed or not is to look at the TSH that was drawn on the same day as the TG. And if the TSH is high, then you know most likely it was a stimulated TG. So a suppressed TG means still on LT4. So this allows me to kind of segue into another paper that's very good in thyroid. It's management of recurrent or persistent nodal disease. And this is something that we have a lot of discussion on with our endocrinology colleagues. Sometimes people get very nervous when they see lymph nodes in the neck and what to do, whether to go ahead and remove them or to just go ahead and do another ultrasound in 6 months, kick the can down the road and see if it's a benign process or not. So these are some guidelines that come out from this paper. The size of the lymph nodes has some impact on whether you do surveillance or whether you do surgery. And for those in the central lymph nodes, anything that's greater than 8 millimeters or anything, excuse me, this is supposed to be lateral, not the second central here should be lateral. If it's less than 1 centimeter in the lateral neck, you can pretty much safely observe it. If it's bigger than 1 centimeter in the lateral neck, it's probably a good idea to go ahead and remove it. And you can follow it again with the same sort of criteria, 3 to 5 millimeters. So if you have, if the lymph nodes are very close to proximal vital structures, such as the nerve, tracheoesophageal groove, the vein, if you already see some sort of indentation in the vein from the lymph node itself, that means that I would probably be more motivated to go ahead and remove it with surgery rather than observe those. And the reason why that we want to be cautious about doing it is because, as we've talked about, is the risk of hypoparathyroidism and unexpected vocal fold paralysis. So one of the things that I think is really important to talk about is whether something has recurred or something that's persistence. Many times patients will come and they say, I had surgery in January and now it's already come back, and it's March or it's April, and it's already come back. Well, if there was never a disease-free period, then most likely we're not talking about recurrent disease, we're talking about persistent disease. And I think that that is a very important differentiation to make, because obviously recurrent disease implies a different biological behavior than persistent. So if you had thyroid surgery, and you had a thyroidectomy, but they didn't look for lymph nodes and they didn't do a pre-op ultrasound, and then you come back in 3 months later with lymph nodes, that doesn't necessarily mean that the lymph nodes popped up between January and April. It may mean that they were there all along and they just didn't get removed. So I think it's important for the discussion of the biological course as well as a discussion with the patient, because many times a patient is freaking out. I just had surgery, I was told everything was out, and now I have these lymph nodes that are popping up in like less than 3 months. The other thing to remember is just because you have a lab value, so let's say that you have a thyroglobulin of 2, and that is on suppression. And it's creeping up. It was like 1.5 last year, and now it's 1.8, and now it's 2.1, and it's slowly going up. And every time you're just, you know, beating your head against the wall, doing all these surveillance ultrasounds, all these scans, and you just can't see anything. That means that you most likely have a biochemical recurrence, which is hard to predict in terms of really overall prognosis, because if we don't have any sort of structural lymph node enlargement corresponding with the increase in TG, it may be just a problem with the assay. It may be a problem with the patient's TSH and how fluctuating their levothyroxine dose is, and therefore their TSH dose, and therefore their TG dose. So it's very important to try to avoid surgery just to correct a lab value. And I'm not a big fan of doing surgery just to look around. Obviously, we already have discussed the risks of surgery for looking for something that we know is in there. But just imagine the risks if you're not really looking for anything that you are sure that you're looking for. So you're flying blind. And I think that that's something that's important. Patients tend to be very anxious with thyroid cancer, and I think that's a combination of both, that we're making them a little bit hyperthyroid, and that causes anxiety and their heart to be racing a little bit, but also this sort of amorphous, well, my TG is going up, but you can't see anything, and therefore what's going on in my body. And so I think that it's important to address those issues with the patient along with the endocrinologist. All right. I think that is all I have in terms of cases. I can probably find some more cases if you want. We have about 20 minutes, but I thought I'd use the time just to see if you guys have any questions. And I'm gonna stop my share. Do you guys have any questions for the well-differentiated thyroid cancer talk, or for any of the thyroid? Tyler raised his hand. Go ahead, Tyler.
Hey, I don't know if I think this is working on Zoom, but I was just curious what your thoughts were on the RFA ablation. I've heard Dr. Sieblick's thoughts a little bit. It obviously seems pretty limited, but was just, yeah, curious what you're thinking.
Oh yeah, that's a great idea. Thanks, Tyler, for bringing that up. So radiofrequency ablation is coming online in the US for management of thyroid nodules. It's reserved for benign thyroid nodules. And I think that it's a very good way to try to resolve the a larger thyroid nodule that the patient doesn't want to have surgery for. Basically, you're just heating up the thyroid with a larger probe. You actually insert it into the thyroid nodule itself, and you heat it up so that it constricts and scars down, and then it disappears. There have been very good outcomes in Korea, in Brazil, which is really where most of the work is being done and where most of the training is being done. I look forward to the opportunity to use it at our institution, hopefully in the near future, although with this current economic results of the pandemic, that might get delayed. But I do think it's important to examine that and what its role might be for our patients. And right now, it would be a cash process. So it would just be like going to get Botox. You would need to pay upfront for the procedure because most of the payers are not approving it right now. Okay, here's another question. If there is a small ultrasound recurrence in the neck found, but TG is elevated, less than 5, but stable, would you watch it? Yes, I would watch it. I think that part of the importance of thyroid tumor conference, as well as having a dialogue with your endocrinologist, is discussing these. I think that through the years that I've had thyroid tumor conference with our endocrinologists are much more sensitive about which ones to biopsy and which ones not to biopsy. Because once you biopsy it and it comes back as a cancer, what do you do with that answer? And what does the patient do with that information? Is it really going to change what you're going to do? And if it's very, very small, and I would say less than 8 millimeters or less than 1 centimeter, then I think it's worthwhile to watch it and see if it grows or not. The other thing is that it can be very difficult to locate such a small mass in the neck. Please comment on my approach for surveillance for well-differentiated thyroid cancer after surgery, plus or minus RAI. Okay, so I think the important thing is to collaborate with your endocrinologist. I think it's important to do TSH, T4s, thyroglobulin antibodies on a regular basis. So you may want to do it every 6 months for the first couple of years, and then at least every once a year. I do ultrasound, not whole body scans, not radioactive, not I-123 scans, and usually do ultrasounds every 6 months for the first couple of years, mainly because of the higher risk for persistent or recurrent disease during that time period. And then correlate that with the TG results. So if we see something on ultrasound, but their TG isn't elevated, then I will have them come back in a shorter time interval to do another ultrasound. If the TG is high and their neck ultrasound is completely negative, then I would look at their chest and I would get a non-contrast chest CT to assess whether there's any disease in their chest. That's pretty much the way that I think about things with regards to postoperative surveillance. Let me just take a few minutes here. Many of you guys may want to develop a thyroid practice when you finish your training. And since we have a few minutes, unless you guys have any other clinical questions, I'll just take a few minutes to discuss how my practice got built and hope that it might be helpful for you guys. So when I first came to Emory, general surgery was doing the lion's share of thyroid and parathyroid surgery. In fact, our residents had to rotate on the general surgery service in order to get their numbers, which is hard to believe right now, given the high volume that we are doing in our department. But that really was the case. General surgery was doing the lion's share of the cases. We were not considered, I mean, sometimes we get called in to do a neck dissection to help the general surgeons along, but really our specialty in our department at our institution really was not the go-to person for thyroid disease. So one of the first things I did was to develop the Thyroid Multidisciplinary Tumor Conference. And I had started that for the head neck group and started the thyroid group probably about 4 years after I started the head neck group. And what that allowed was mainly for an open discussion about cases, about what, in a subtle way, what we bring to the table as compared to other types of surgical backgrounds. And for the endocrinologist to understand, oh, wow, these people also do surgery, and this is the way they approach surgery, and this is the way they think. And when they do their surgeries, we get 45 lymph nodes out rather than 12 and things like that. So there, it was an open discussion where everyone was invited to come and present their cases and talk about things, but it allowed for a collaboration, a camaraderie, and a trust to develop. Then I started to learn ultrasound. And I think that all of you have a head start on that than I did. When I went through training, we didn't do ultrasound. In fact, ultrasound really wasn't really part of a surgical armamentarium. Even in the ER, we didn't have the FAST exam to look for blood in the belly. So ultrasound really wasn't in the hands of surgeons at the time that I was training in the 90s. So now you guys have the ultrasound in your clinic most of the time. I would say probably all of you would have an ultrasound in your office at this day and age. And to have that in your hand, to have our knowledge of the anatomy of the neck, it really makes learning ultrasound a lot easier than for a radiologist who has very limited time in the neck and knowing the anatomy, as an example. And then, as I mentioned early on, a couple hours ago, it really is pattern recognition. And our minds are really visual. And so we look at things and we can really try to remember it. And the more ultrasounds you do, the more that you're going to recognize what's important and what's not important. Oh yeah, I remember that. Oh yeah, that's really weird looking. I've never seen that before. And I think that those are all things that are very important. So doing ultrasound in the office, offering ultrasound biopsies, was what I started doing in my practice. And that really increased the amount of referrals into our clinic. And because it became a one-stop shop thing. The primary care physicians, the outside otolaryngologists, outside surgeons, outside endocrinologists, even internal endocrinologists knew that if they sent a patient to our clinic, I would do the ultrasound, I would do a biopsy if necessary, I would scope them to look at their cords, I would give them a plan of action, and then send them on down the road. And I think that last piece of knowing ultrasound, learning ultrasound, offering the service of doing biopsies, and then being the first to offer molecular testing for indeterminate nodules really helped get my name out and getting our department out in terms of the go-to people for thyroid and parathyroid disease. So I do think that if you want to, whether it's thyroid disease, whether you want to have a niche in RFA, or you want to have a niche in sleep or sublingual immunotherapy, I think it's important to try to figure out how you can craft your message so that's unique and sincere, not just, you're not a quack, you know your stuff, and how would you convey that? It's also important to get involved in the societies in your city or in your region. So for example, if you wanted to develop a more robust sleep practice, then get in with a pulmonologist, get in with a cardiologist, get in with those people in terms of going to their local society. So I became a member of our Georgia chapter of the American Association of Clinical Endocrinology, which by and large, a lot of the discussion is about diabetes, which I have learned a lot more about diabetes now than I ever have learned before. However, it just allows you to get in with the community so that they know who you are, and also it helps to garner trust. All right, I got a question, so I can stop talking. You don't have to listen to me. When doing an office ultrasound, is it necessary at times to send the patient for formal ultrasound? That's a great question. So when I started out learning ultrasound, and it really depends on your comfort level. When I started doing ultrasound, I would have a formal ultrasound done in radiology as well. And I didn't charge for my ultrasound because I was still learning, and I didn't feel like it was ethical for me to charge them and then have them go to radiology and have another one be charged. So once you get to a level where you feel like your office ultrasound is just as good or better than the formal ultrasound done in radiology, I do not think you need to send them for formal ultrasound in radiology. And that might take some time for you, depending on your practice location, as to whether you can actually help them understand the different levels of the neck. And this is what we had to go through at Emory. I went through a lot of training with the ultrasound technologists, because they're actually the ones who are doing the ultrasound. They actually capture the images, and the radiologist in the office just reads the images that are captured for them. So if the technologist doesn't do it right, the radiologist isn't going to get it right. So it's important to have that information as to how comfortable you are with the ultrasound technologist in looking at all the levels of the neck, looking at what you're interested in the thyroid and the central neck, before you can decide. And sometimes it might be easier for you, and you might be more adept at doing it yourself in the office than sending it to radiology and doing it at a freestanding facility. Okay, well, it looks like all of your questions have been answered, at least for today. And I just wanted to, you guys have a few minutes before the next talk. So I just wanted to say thank you for the opportunity, and I think this is great what University of Kentucky has done in terms of being the ringleader in making this happen. And hopefully all of you will stay safe and try to stay busy, and like me, struggle with what you cannot control. Bye, guys.
Thank you so much. Great talk. Appreciate it.